Hey, this is Walt Lubbers. Wanted to talk to you about ketamine today. And the reason for that is not only do I really just like ketamine and I like talking about it, but I think ketamine is a really good drug. And I think we're going to see more of it in the pre-hospital realm. Even if you haven't gotten used to it thus far, even if you have never seen it actually used, you probably will in the next couple of years. And hopefully probably everybody's going to go to it. Now we're hampered a little bit by the sort of technical aspects of it. Where do we get the drug? How do we get the drug? Is it really expensive? What do we do with it if we can't get the concentration we want? All that's out there. We'll solve those problems. But I wanted to give you a little idea about ketamine itself and why I think it's so cool. So ketamine is a dissociative anesthetic. Now, it's not just an anesthetic. It's not that you just have to use it in the OR, but the way that ketamine works is it's not like, say, morphine or Dilaudid or something like that, where it just sort of dulls the pain receptors. What it does is dissociate kind of the conscious part of your brain, the part that's going to receive the pain signals and attach an emotional component to it that says this is bad. It's going to break that off from the rest of your thinking brain, the rest of your sort of biological functions, and it will go someplace else. But even though your body may perceive, oh, there's some sort of stimulation, there's something going on, you are dissociated from it entirely. So if you give someone a dissociative dose of ketamine, the person remains conscious. They keep breathing, they keep their airway reflexes up, they keep all the stuff that we want, but you could, say, amputate their arm. While they're fully conscious, essentially, which is one of the things that we kind of look at doing in terms of why it would be great for pre-hospital stuff. Because we can extricate somebody from a car with it. We could, again, amputate their arm if they're trapped under a boulder. We could do any of that stuff with just a dose of ketamine and maybe a little supplemental oxygen. So ketamine's really cool. We've probably seen pictures like this where the kid goes to the dentist and says all kinds of weird stuff, or he looks like he's probably in like an ER or something like that. Ketamine will kind of give you this cool trip, and that's why it's a good recreational drug as well, or rather it's a well-liked recreational drug if you can get it. And again, it's pretty safe for use in things like sedations because the person keeps on breathing. Now, what does the person that's gotten ketamine look like? What's their picture? Well, it basically looks like this. The person stays awake. Their eyes are usually at least halfway open. They don't look like they're asleep, but you can come at them. Again, you can drain their abscess, you can move their arm around, you could cut a part of them off, and they probably wouldn't really respond to it, at least knowingly. Some of the other stuff that's interesting about ketamine, you maintain your airway reflexes. So you maintain some cough, some gag reflex, your ability to continue to respire during a ketamine dissociative phase. One of the other things that's critical about this is it makes you hypersalivate a little bit. So not only do you get the open mouth continuing to breathe, tongue lolling out instead of falling in the back of your throat, but you do get some extra salivation. It can give you a little bit of tachycardia. It can give you a little bit of bump in your blood pressure as well, which could be a useful thing if you've got somebody that's critically ill or hypotensive. Not only does it depress sort of your ability to respond to things, but it amps up the other stuff. It gives you a little sympathetic boost when you get it. So if you give somebody ketamine, a lot of times you'll see their heart rate go up a smidge, their blood pressure go up a smidge, not a whole lot, but it doesn't depress all the other stuff that other pain medicines might. So one of the other things to be aware of with ketamine is you'll have probably seen something about ketamine increasing intracranial pressure. And the studies that back that up, or the studies that sort of led people to think that, are not very good studies, and really this isn't a clinically significant thing. It may increase when you give somebody a dose of ketamine. It may cause their intracranial pressure to increase a little bit. So if you've got a subdural, or if you're herniating or something like that, folks have thought for a long time, oh, you got to stay away from ketamine because that's bad. What we actually find is ketamine's probably actually neuroprotective. It actually is probably a really good thing because it helps preserve some of your preserve some of your brain function after these bad injuries, it seems. But it's certainly not the really bad stuff. Oh, you can't use ketamine if they got a head bleed. No, it's absolutely not true. You can use ketamine. You probably should use ketamine because it's such a good dissociative, and because it actually decreases the amount of stimulation that the person's going to get. So ketamine, good. It's fine to use in intracranial hypertension or in somebody with a bleed or something like that. One of the other concerns about it is always using it in glaucoma. Again, this is probably sort of backed up, or somebody with intraocular pressure that's increased. The word has always been that you don't want to do that. Well, again, probably overblown, probably doesn't really matter. But as a matter of course, you may want to avoid it if they've got glaucoma and you think that that's where their pain's coming from. Now, one of the other things that can happen with ketamine that you got to watch out for is this thing called an emergence reaction. There's really three main side effects that happen when you give somebody ketamine. One is they get nauseous, and this happens pretty frequently, so you got to pre-medicate these guys with some Zofran. Zofran, with 4 milligrams Zofran, most people do just fine. The other thing that can happen is this thing called an emergence reaction, which is as your brain is sort of, the way I describe it to patients is, as your brain is sort of recoupling, as the conscious and unconscious and autonomic parts are sort of coming back together and everything's rewiring itself. This can be sort of like waking up from a dream, but you're not fully awake, but you still kind of see that, so it's just waking dream kind of thing, like a night terror sometimes. Some people find this pleasant because they have a good trip with it. Some people have a really bad trip with it. And some stuff you can do to kind of decrease that. Number one is to decrease the amount of stimulation. So if you get somebody that is calm when they fall asleep or when they get the ketamine, they're more likely to be calm when they wake up. You can turn off the lights, you can turn down the music, you can stop yelling at the person, and just let them kind of wake up slowly. Decrease the amount of stimulation, that usually gets better. Emergence reactions can be really profound. People will just like scream and yell, and they'll kind of go absolutely crazy, look at this wide-eyed look, this terrible kind of thing. If that were to happen, we give them a little bit of Versed, or you could give them, your benzodiazepine of choice. Monitor their respiration, of course, but let them fall back asleep for, another half hour. When they wake up, they're usually doing better. One of the other things you got to kind of watch for is this thing called laryngospasm. And you can't really see it on here, and I'll go into this at another point. But laryngospasm, you can sometimes get literally a spasm of your vocal cords that's so tight that you really can't pass air through it. And that may start as like a stridor, or it may be somebody that just completely stops breathing for all of a sudden. Remember, I said ketamine doesn't make you apneic. But if you get laryngospasm, you could sort of become apneic. You may try to breathe, but because your glottis is closed, you literally just can't get air through there. So you got to watch out for that. That's relatively uncommon and relatively straightforward to fix. If you know that it's coming, you can do stuff about it. But again, another talk for another time. We'll hit on it in just a little bit. All right, so those are some of the side effects of ketamine. The side effects are sort of, to some extent, related to the dosing of it. And maybe they're not so much side effects, maybe it's just what happens when you give somebody X amount of, X dose of ketamine. But here's kind of what goes on with that. So when you start at relatively low doses, and let's convert these over to milligram per kilogram doses, because that's what we're mostly going to be looking at. So if you start somebody at a low dose, 0.1 milligram per kilogram, 0.2 milligrams per kilogram, you're in an analgesic kind of region. You give them the medicine and they feel better. They don't get dissociated. They don't completely, you can't cut off their arm or something like that, but it's really good pain medicine. It's so good, in fact, that sometimes that's all you need to even do some of these more painful procedures. 0.1, 0.2 milligrams per kilogram per dose, it gives you a pain relieving dose. Now, as you get a little bit higher, up to like 0.3, 0.4, then you start to get into the area where like things are kind of fun because you get a little goofy. This is where recreational ketamine users kind of like to be, somewhere between probably 0.3 and 0.5. Because that's the part where things are a little bit loopy and you get that little bit of buzz and everything else, and it's kind of fun. It's not really where we want people to be because it's awfully close to partial dissociation. So if you get somebody about halfway to the complete dissociation dose, if you give somebody, say, half a milligram per kilogram, 0.5 milligrams per kilogram, then you can get them, unfortunately, partially dissociated. And this is the guy that's lost essentially all inhibition and reason, but is not to the point where he's not wiggling around or anything like that. So you'll get folks at this point that get really bad psychomotor disturbance or psychological disturbances, at least while they're on the drug itself. This can be a really kind of dangerous time because these folks can get awfully agitated awfully quickly. So either we want to stay low or you want to go high. You just don't want to meet that much in the middle, because if you're trying to be a little cautious and you kind of underdose it, then you end up with a lot of the bad psychiatric side effects. without the benefit of being dissociated. Once you get above 1 milligram per kilogram, which is kind of your starting dose for sedation, if you were going to do a procedure or something like that, above about 1 milligram per kilogram, that gets you dissociated, the point where your brain disconnects from your body, and you could do whatever you want to the body, and the body still knows that something's happening, but the brain can't put stuff together so that you'll be able to do anything about it. Also, you get amnesia during this point. You get good pain control. It's not that you're like paralyzed or something like that. It literally is kind of an uncoupling of your brain. So 1 milligram per kilogram and above, dissociative doses. 0.1, 0.2 is about our analgesic dose, where we're going to mostly be. And by the way, if you give somebody more than 1 milligram per kilogram, thereabouts, it tends not to make them, say, more dissociated. It tends to maybe increase the side effects a little bit, but it lasts longer. So giving somebody an overdose of ketamine, a quote-unquote overdose of ketamine, probably actually doesn't do a whole lot other than keep them down for a longer period of time. Now, just to rehash that, if we're going to give somebody a sedative dose, then we're going to give them 1 to 2 milligrams per kilogram of IV ketamine. And again, this would be somebody that maybe a physician's out with you and you're responding, and you want to untangle his leg from around the gear shift or something like that. Milligram per kilogram IV, you can do whatever you want to the guy after that. Now, you should have end-tidal CO2 monitoring, you got to have SAT monitoring, you got to have cardiac monitoring, make sure this is all going okay, because these people are potentially sick. But that's what you would do. If you didn't have an IV established, you can give this IM, and it's about 45 milligrams per kilogram, should give you a dissociative dose. Of note, you could also do this for agitation, because a lot of times we don't want somebody with agitation to get the analgesic dose. We want them to get a sedative dose or a dissociative dose, which again is 1 to 2 milligrams per kilogram IV or 4 to 5 mg per kg IM. If we did want to give just pain relieving, we'll give them somewhere 0.1, 0.2 milligrams per kilogram. And that will make even this leg wound, which is pretty awful, probably fairly tolerable, at least for the ride in, until we can get something else done. Now, I brought up agitation again a little bit. Ketamine is a good anti-agitation drug, an anti-good muscular naked man walking around the street drug. So if we were going to take this guy down, I have two kind of favorite drugs for this. One is Versed, and it's 10 milligrams of Versed in the thigh, and there's very few people that can resist that. If you don't want to use Versed, because there are some respiratory depression kind of side effects, you can use ketamine with it. Dose of ketamine for Steve here is 4 to 5 milligrams per kilogram IM, which you'll notice is the same as the dissociative dose that we might use for sedation. And that's basically what we want. We want this guy procedurally sedated so that we can restrain him and keep him down and get him to the hospital. Now, unfortunately, all good things have some kind of detractor, some sort of downside to it. Everything I've told you about ketamine so far should seem pretty good. Like, this is a really good drug, and it is a really good drug. However, there are people that are out there that are sort of detractors for it. And I'm not saying this specifically because they don't like ketamine and I like ketamine and I think they're jerks. I just think they're maybe misinformed. So if you look out there, this was a New England Journal Watch, when you see the line, and this is something like you might read in, say, GEMS or EMS 1 or something like that. You may see this headline, IM ketamine is not a good first-line option for severely agitated patients. And unfortunately, this gets looked at, and folks that are in decision-making capacities may read that, and that's all they might read, or they may read this thing itself. Well, this problem is that this thing itself is not actually an article. This is a review of an article that talks about ketamine. So this isn't even data itself. This is just somebody's opinion. So you can't really go with that. Unfortunately, though, that's led to kind of a little bit of a stalemate or a little bit of a delay in getting ketamine widely used, especially for things like agitation. Pain relief, we can make our case a little bit easier, but there's some hesitation, at least in Kentucky, on whether or not we should be using this for sedation for severely agitated people. And so it's kind of gotten us away from being able to roll it out faster than we would like to be able to. But I'd like to hit on why that's all bull. essentially. But this is one of the reasons that EMS is constantly going to have trouble, because we don't take the time to actually read into the thing. And it's not us, it's not the ground level provider, it's somebody who reads something but doesn't read the entire thing. And that's why it becomes a problem. So here's the actual article. Not the review of the article, but the actual article that was referenced just a second ago. What this was, real briefly, is y'all know Hennepin County in Minnesota. This was Hennepin, so big EMS group, big research group. It was a prospective study, meaning we knew we were going to do this. We're going to collect the data ahead of time before we actually start doing it, even though it's maybe not a study so much as a report on stuff. But we knew we were going to collect data, is what they're saying. What they looked at was if you gave pre-hospital ketamine for profoundly agitated patients. And profoundly agitated patient was somebody with physical violence to himself or maybe to somebody else, and chemical or physical restraints may be required or may not be able to be safely used as we normally would. Plus they had to have a severe agitation score, which is a 4. It doesn't really matter. They were severely agitated, let's say that. And to be included in this study, you had to be transported to the study hospital. So you had to be crazy, you had to have a severe agitation score, you had to be a danger, and you had to go to one of the be taken to a study hospital, which not all the hospitals in the Minneapolis area are study hospitals, or in the Hennepin County, let's say, service area, are study hospitals. So, the dose of ketamine that they gave for these folks when you were severely agitated was 5 milligrams per kilogram. And then they looked at the time to sedation before you could get essentially control of this person. So it was a 5 milligrams per kilogram IM. And then how long did it take before the person was sedate? And then they also looked at, do you need additional sedatives? Were there complications? Did the person get intubated? Were there EKG or lab data? And how long the person was in the hospital? So, out of 158 people that were sort of slated to be in there, 49 were officially enrolled. Now, it's worth noting that a lot of those, most of those people probably, about 100 of them out of that 158, didn't get included in the study. They got ketamine, but they didn't get included in the study, if I remember correctly, because they didn't go to one of the study hospitals. Okay, so there's 100 people that we don't know what the heck happened to them. And the total dose was right around 5 milligrams per kilogram IM. It took about 4 minutes after getting an IM shot of ketamine, usually in the thigh, to become sedate or get their agitation score down to a point where it was okay to restrain them. Of note, about 14% got additional medications. There was some hypersalivation in about 1 out of 5 people. About 1 out of 20 had some vomiting. About somewhere around 1 out of 20 also had an emergence reaction, which again, when you think of these guys, these are probably pretty agitated folks. As I said, they may be more likely to come out of it a little bit worse. And there was 1 patient death, but it was unrelated to any of the above here. So, one of the concerning things out of this whole study, and the reason that you'll see people really kind of amped up about it, was that they reported that 57% of the people that were agitated that got ketamine got intubated after that. Wow, that's a lot. Almost 60% of the folks that got ketamine then got intubated. Holy crap. And 18% of those guys stayed intubated over the next for greater than 24 hours. And there are reasons for the intubation are sort of listed up there. Airway unprotected, not otherwise specified, as number 1 far and away. And then hypersalivation, respiratory failure. Only 1 person was documented as being, or was said that they were hypoxic, and it's unclear exactly what that means. Airway was the number 1 reason that people got intubated. And again, if you look at that, you're probably like, whoa, holy crap, 60% of the people that got this drug got intubated. This is dangerous. This isn't like maybe there's a little something and there's room for error. 60% of these guys got intubated. Holy crap, this is really bad. However, when you really look at it, here's what the actual breakdown was. Whoops. When you look at the folks that actually got intubated, of them, about a third got intubated by 1 person. So 36%, I think, is the number, were intubated by 1 doctor working overnight. That should raise some red flags, because these aren't small hospitals. It's not that there's only 1 doc that works during the day and 1 doc that works during the night. This is 1 person is intubating a lot of these ketamine folks. Okay. Of note, another 21% got intubated by fellows. And fellows are generally younger doctors who maybe have a little bit less comfort level with letting somebody sit with a quote-unquote unprotected airway, or with some kind of concern about maybe they haven't seen that many folks getting a ketamine sedation. Because when you give a ketamine, when you get somebody on ketamine, they will look and be documentable as probably a GCS of 3. Maybe their eyes kind of stay open, but they don't really respond to you. They don't talk to you. They don't really open their eyes or have probably purposeful movements. That's the point of the ketamine, though. When we talk about the GCS being 3, oh my God, it's so low. Well, in this case, it's 3 because the person doesn't need to do anything, but generally, again, their airway reflexes are protected and they're usually not hypoxic or anything like that. So GCS 3 on ketamine, or like a GCS 111K, is a lot different than just somebody with a GCS 3. Totally different, totally different. But maybe not everybody that intubated these folks had as much comfort level letting that person kind of sit. So if you look at that list of folks that got intubated because of it, really maybe the one hypoxic person was the person that's definitely, yeah, maybe they need to get intubated. Everybody else, highly questionable. But again, about 60% of these guys, about 2/3 of these people, got intubated by a very specific subset of folks. It's also worth noting that about 100 of these people, about 2/3 of them, we have no idea what happened to them because they didn't go to a study hospital. We can't follow them up. So these guys got ketamine, but we don't know where, or I'm sorry, they were in the study, but we don't know exactly where they would have gone to, so we can't really include their data in there. Which is frustrating because who knows what happened to them. Maybe all 100 danced out of the hospital, and that makes all these statistics absolutely meaningless right now. That's a really important part of this study as well. One of the other really important parts of this is we don't know how many of these folks that didn't get ketamine or might not have gotten ketamine, they got Versed or Valium or something like that, how many of those folks got intubated afterwards? Because if you've seen somebody with excited delirium, a lot of these folks are going to get put down in the ED. That's just what's going to happen to them because they're severely agitated, because either we can't tie up a nurse doing it, which is a lousy reason to do it, but either we can't tie up somebody keeping them in bed, or we need to get a scan of them, we can't get them to hold still, or they're threatening people, or they're dangerous, or something like that. That's all very possible as well. So we don't know what happened to all the folks that didn't get ketamine, if they got intubated as well. Maybe 75% of those guys got intubated. Again, we don't know. It's just the data that's reported to us. That's all we can go with. So that study is one that people have talked about and people have raised a lot of eyebrows about, but I don't know that it necessarily says everything that people are attributing it to. I think it says that folks with excited delirium that are severely agitated by EMS are likely to get intubated, especially if you come in while one specific guy is working. But I don't know that it says that ketamine is dangerous because we don't have the full picture with it. In terms of pain control, which is maybe more what we're looking at, this is here's a really good example. Now, there's lots of cases of ketamine being used for pain control that's documented in military and special operations. Been using it for a while and shown to be effective and doing basically everything that we want it to do. Here it is in a civilian setting. So this is in Australia. And the Australians are kind of sort of the same EMS system as in the United States, so we could probably generalize a lot of this. It's not totally different. Everything's a little bit different, obviously. But this is 12-month retrospective analysis of their use of ketamine. So basically, they just looked at everybody that got ketamine in the field, whether it was for RSI or agitation or pain control or some other reason. They looked at that and just said, here's what happened. So specifically looking at pain control, because we're just mostly talking about pain control right now, the folks that got pain dose ketamine, there were about 100 of them, 104 I think is the number. In general, they got a dose, usually the average kind of dose, median dose was about 3 doses, and each dose was somewhere, if you do the math, works out to about 0.2 milligrams per kilogram. So about what we're talking about doing here. Now, again, the scary thing, if you look at this, they're going to say that 8 of the people that got pain dose ketamine got intubated in the ED. That's 8 out of 50, which is, close to 20%, which is still high. If you think of all the people you've ever given fentanyl to, a pain-relieving dose of fentanyl or Dilaudid or morphine or ketorolac or anything else, how many of those guys ever got intubated? Probably not many of them. But 8 out of 50 of these guys got intubated after pain dose ketamine. And you may ask, well, what in the world? Your lubbers, this is dangerous stuff. I'm telling you, even at low doses, all these people are getting intubated. This shouldn't happen. Well, again, you've got to look at the whole story in order to make sense of it. So thankfully, these guys did a really good job of actually putting out why, what the circumstances were behind a lot of this, a lot of these people getting airway management in one way or another. So I've kind of taken this table and cut it down a little bit, but this just shows you what happened to each person. So if you look at the top one, here it gives you the dose, and it gives you the reason that the person was intubated. And by the way, all these guys got intubated in the ED. They didn't get intubated in the field. It was all in the ED. So maybe a little different environment. But look at the top guy. GCS, why did he get intubated? GCS 12, and he was agitated. Well, that guy's going to get intubated anyway because he's a multi-trauma patient, and you're going to want to get scans of him, and you need to do stuff to him. So he would most likely, almost certainly have gotten intubated anyway, my guess, regardless of the ketamine. Likewise, the guy below him, GCS 11. Why do we do it? For the CT scan. Exactly as I said, the guy's agitated. He won't hold still for his CT scans, or we need to protect him during his CT scans. They go ahead and take his airway. Probably had nothing to do with the ketamine itself. There's another multi-trauma. There's a guy in cardiac arrest. Traumatic cardiac arrest, that probably is not due to the ketamine, my guess. GCS 11 combative, GCS of 9, and we're doing it for airway protection. And then one of the ones at the bottom there, pain and humanitarian, the guy had his upper extremity amputated. So they intubated him because that hurts like hell. And probably the ketamine was given for the same reason, because it hurts like hell and we need to get this guy's pain under control. So here we've got that list. So the 8 out of 50 people, all of us would say that that's probably a pretty reasonable thing to do for most of these guys. Now, what was their GCS ahead of time? Yeah, did he go from a GCS 15 to a GCS 12 and then got agitated and that kind of thing? Maybe. But by and large, ketamine in this study for pain control seems to be safe. This seems like something that was going to happen probably regardless, and in a lot of cases was just something that needed to be done. And the reason we gave the ketamine rather than like morphine or something like that was probably because they had really bad injuries, or they were hemodynamically unstable, and we wanted to give them something. So that's my kind of read on this story. And by the way, of the other folks, they documented an overall 17% intubation rate for everybody in the ED, or everybody that was brought in that got ketamine. A lot of those guys were because they got ketamine because they were getting RSI'd. So of course those guys are getting intubated. Or they got ketamine because they were agitated. So same thing. Just looking at the number, just reading the abstract doesn't really always tell you the story. So that's a couple of the recent news on ketamine. My takeaway, ketamine's a pretty safe drug. Ketamine's getting a bad rap because you'll see stuff like this, and it's going to be sort of like the backboard. A lot of this is built on not so great data, and we're going to have to actively fight a lot of it and say, no, that's not actually what that study says. What the study actually says is not that ketamine's dangerous. It says that this one guy intubated a lot of people, or this group intubated a lot of people, or maybe it's just that, again, folks that are severely agitated that get brought into the ER have a high chance of getting intubated. So, just like with the literature surrounding backboards, I think we're going to have to fight against this. Otherwise, we're going to be putting somebody on the ketamine backboard for the rest of eternity, and we don't want that. So, ketamine's good. Ketamine's a cool drug. Ketamine works real well. You do have to be a little careful with it. It's not something that we can just throw around willy-nilly, but if you did throw it around willy-nilly, it is probably safer than almost any other drug I can think of to be thrown around willy-nilly. So, ketamine's a good drug. It's good for pain control. It's good for agitation. And if you follow the evidence and you really look at it, the EBM is probably pretty good. This is on the good side. So, if you have any questions about this, email us at emsgrandrounds@gmail.com. And don't forget to check out the website, which is where you probably got this from, emsgrandrounds.org. Again, I'm Walt Lubbers. Thank you very much for your time.